Hello, social workers, mental health professionals, and change agents. Welcome to another episode, season 5 of the Social Work Rants podcast. I'm your host, Bash Moreno. Saludos a todos, greetings, everybody, wherever you tuning in, whether it be on YouTube or listening to the podcast on all audio platforms. Make sure you follow the podcast on Instagram at the Social Work Rants podcast. That is all one word. Follow the podcast on Twitter at Social Work Rants and hit the like button on Meta, aka Facebook. Type in the Social Work Rants podcast. Hit that like button. Subscribe to the podcast on YouTube. Rate the podcast on Apple Podcasts and Spotify. Leave a comment. Let me know what you think. I'd love to hear your thoughts on the podcast. Um, there's also podcast merch. Go to www.triumphthroughpain.myshopify.com for hoodies and t-shirts featuring the Social Work Rants podcast. This episode of the podcast is brought to you by Bat City Entertainment, your home for holistic online self-care featuring poetry and Zumba classes featuring my book, Trying Through Pain, How to Maximize Your Full Potential During Hard Times, and currently out on Amazon on paperback and on Kindle. And also make sure you get the book Latinx and Social Work Volume 2. I'm a contributing author. It's already a #1 bestseller on Amazon, so make sure you get the copy of that. And speaking of Twitter, I mention all the time, Twitter is a wonderful resource for social workers, and definitely met this gentleman through Twitter, Dr. Liam Curran. We're going to talk about FASD, what is it, and how it relates to child welfare today. Dr. Curran, how you doing today?
Yeah, I'm doing well. I'm doing well, Baz, and thank you for connecting.
Yeah, absolutely.
Yeah.
No, pleasure having you on. Definitely wanted to fetal alcohol syndrome is something that I've learned within like the last, I would say, 5 to 7 years. I've interviewed somebody on season 1 about the podcast regarding fetal alcohol syndrome. Someone who's a parent or with a child who adopted a child with fetal alcohol syndrome, and just kind of talk about what is it and how the struggles, parenting somebody with fetal alcohol syndrome, and talk about, how people, who are dating and, not even thinking about, having kids, and then they go out party, have, and meet somebody, and have sex, and then like, 9 months later, and have a baby, and then like a couple months after that, start seeing some signs, and it's like, I drank 10 months ago, and then all of a sudden we have these issues. And it's not just like women, is also research out there. There's men could affect, with their sperm, and having a baby being born, at least with a mild case of fetal alcohol syndrome disorder. So if you've done a lot of research in that, take it away. Just let people know what you do regarding the field and how it relates to child welfare.
Yeah, sure. I guess, Baz, one of the things I'll say to you firstly is that, I primarily my work up to this point, I qualified as a certified FSD educator in 2011 under a program of the Center for Diseases Control here in the US. And that program was competency-based curriculum development. I went on a kind of residential down in Wisconsin, and then I had to go back to Europe and do some post program and get assessed by my peers, and then send it in. Anyway, I became certified as a fetal alcohol educator. And I did a lot. I suppose the reason I did that is that because I'm accidentally in this world. And in that sense, back in my practice, my social work practice, way back, I'm not going to say how long, but I had a very, very complex pre-birth risk assessment. And that risk assessment was regarding substance misuse in pregnancy, etc. That was part of the pre-birth risk assessment. And it was the first kind of eye-opener to me as a social worker, because I was hearing, certainly I remember being in a meeting with an obs and gynae doctor, and this obs and gynae doctor talking about the potential risk to the unborn because of the substance misuse. And that was kind of a light bulb moment for me, because I'm thinking, wait a minute, as a social worker, we're constantly taught about, you know, the toxic trio of mental health, of addiction, of all these things that happen to the child post-birth.
Right.
You know, but nobody ever talks in social work about what might be happening pre-birth. And this was the first time. And that kind of troubled me a bit. So I went back, I was in Ireland, and I went into to study at Trinity. And I chose to do a master's asking the question if drug and alcohol use was a child protection concern. And that kind of changed my life. It wasn't intended. I was trying to wrestle with this question that I'd had from the pre-birth risk assessment for myself. Right. And I did the study, and before I knew it, it was taken up by the Society for Knowledge in Ireland. It got part published. And then the state system in Ireland put it on their website. And next thing I know is I'm getting emails from different parts of the world because they found my thesis and they want to talk to me. And I remember I got one from Brazil. They wanted to publish my thesis and all that sort of thing. So I stayed at it. I've done a number of publications in Europe. Probably the last thing I did before PhD, I co-authored a book called Understanding Fetal Alcohol Spectrum Disorders, a guide for parents, carers, and professionals. And I co-authored it with a foster carer in the UK. And that book has done extremely well around the world. It's sold well here in the US, which always surprises me, because I'm saying, I want to kind of caveat to people that if you read me, a lot of my work is very central to my culture, to Ireland, and a lot of my publications are. But sadly, social media take publications and they go around the world, and right, you know. And I think that one of the things that most people wouldn't rate but know that is that Ireland, we have a kind of difficult relationship with alcohol, and we have, according to the research, we have the third highest birth rates of fetal alcohol in the world. And we have documented, epidemiologists have documented 82% drinking rate in pregnancy, which is crazy high.
No,
I'm saying
absolutely.
crazy high because, like, here in the US, your latest statistic nationally is 13.5% is the national figure for drinking in pregnancy in the US. Now that varies. I know that, say, here in Providence, where I'm based, the figure is 16.4. I think you're in Delaware, which is 11.6 in Delaware. So your figures here in the US are very, very good in comparison to Europe, because Ireland has got very high. The UK has come in at, I think, 71% drinking rate in pregnancy. So Europe is still very much in the doldrums on this one. And right. The impact, I suppose, on social work in Europe, and that's where I was doing my work. I was doing CPD education with social work in services. And I know that from my experience of talking with social workers, that social workers are very, very frustrated with this, because they are encountering these children in their interventions, in their casework, and they tend to have no training, they have no policy, they have no procedure, and it tends to be, quite often they can find themselves in a subservient role, because it tends to be the caregiver, or a foster parent or adoptive parent, that is kind of coming at social work saying, we want help, we want help. And, right. And social work is quite often kind of caught unawares, because again, I'm saying very little acknowledgement of it in social work undergraduate education, very little acknowledgement of it in any policy procedure pieces. And so that's kind of my background. I'd say I've been training in Europe and training social workers doing CPD. But you asked me, like, what is FASD? And a lot of people, I suppose, one of the concerns I still have of 10 years of this work is that a lot of people perceive it as a medical issue. And that's only a medical issue. And therefore, What's it got to do with social work? Or what's it got to do with child welfare? And I think the problem is, like, that there is significant amount of evidence of its impact on child welfare.
Mm-hmm.
But let me go back first to what is FASD. Let me take you a little back on the 50 years of research, as I say. In 1968, Paul Lemon in France and colleagues brought forward the first real modern day piece of literature showing that prenatal alcohol exposure had this potential to damage and harm the fetus. The problem with Paul Lemon's work in France was that it was in French, so it didn't travel very well. And the second problem with it is that he didn't really offer a solution. He offered a paper, but not a solution. And that kind of traveled in a sense that it was then Jones and Smith in Seattle, I think, or in Washington, I can't remember where they are based, but they wrote a paper that came out in the Lancet Journal in 1973, and they really defined fetal alcohol syndrome, FAS, in 1973. And in that paper that was in the Lancet Journal, they documented a procedural piece to deal with it. And that's kind of our modern American starter point. You roll on then to 2004, and in 2004, the CDC brought out the FASD, which was a term that was constructed to encompass a number of effects that are found in children that are prenatal alcohol exposure. So we already had the FAS, but then we came to partial FAS, then we came to, all these other conditions that were potential under it. So that was the 2004 was the formal link of FASD that we know today. But at that point, it was very much seen that FAS, fetal alcohol syndrome, has a clinical diagnostic guideline. The conditions within FASD don't, because one of the kind of startling facts of the fetal alcohol discourse is that only about 15% of children will be born with fetal alcohol syndrome. So it's about 85% will be born where they have no visible feature. So they have normal structural development. So they look normal, but they're having difficulty because prenatal alcohol exposure has damaged maybe some of the fine neurons or the synapses connections that were going on, especially in the third trimester. That this is the risk part for the fetal brain damage is in third trimester. So that problem from 2004 to the present day in 2022 is still a problem, because we're still struggling with any sort of clinical diagnostic procedure to capture that 85%, as I call. We're fine with capturing the fetal alcohol syndrome. I think the issue there is that the child has facial dysmorphia. It has the thin upper lip. It has a smooth philtrum. It has the palpebral fissures of the eye. So the visible features are there, and you can diagnose even without confirmation of prenatal alcohol exposure. The 85%, so much more difficult because they have no visible features, and most of the time they're in the care system. So therefore, we have very poor opportunity to actually confirm prenatal alcohol exposure. And even if the social worker was to try and do that, quite often they'll go back to maybe the maternity hospital and say, I'm looking at prenatal alcohol exposure, this child, blah, 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 and this child was born here. Could you tell me if there was any prenatal alcohol exposure noted on the postnatal or prenatal files? The usual response of the hospital is, that's data protection. I can't give you that. Yeah,
right.
and so that becomes a problem, and you have to go through all these long rigmaroles to try and find out if, and the chances are there's nothing written from a Europe perspective. There's probably nothing written on the prenatal or postnatal file around alcohol, because it's just not on people's radars. And I say it's not on the radars. I'm saying that society is a little bit kind of blind to this, or they think that it's just a small problem that is, you know, in the child welfare or in foster care. It's just a small problem, and therefore we don't have to worry about it.
Right.
The reality is, though, Baz, like, you know, we have prevalence studies, whatever. You know, I mean, Ira Chasnoff in 2015, a Chicago-based researcher, gave a 29% prevalence rate of fetal alcohol in the child welfare system. In Canada, I think Lang put it at 16.9. And then it kind of, you know, the UK, a researcher called Selwyn put 30% in the child welfare system. It kind of keeps going in a sense that, like, you know, that Pavlova in 2019 said that the rates of FSD in our child welfare system is probably 32 times higher than non-impacted children. So that, you know, we have this kind of overprevalence of FSD in the child welfare system.
Right.
And I suppose my challenge in a sense of trying to engage child welfare or trying to engage social work is I'm saying that we have this 50 years of research. Why didn't we know this? Why don't we know this?
Right.
And I think the worrying sign now, and I think one of the things that evolved in my doctoral study, really, because I was doing grounded theory, I ground down, because grounded theory makes you do that. It makes you dig. And so my doctoral study now has a number of child fatalities of the child welfare system, and their children with fetal alcohol, et cetera, et cetera. So the public health coroners are writing about these children. A paper came out in Canada there 2-3 weeks ago, and it was Dorothy Bardry, who's a child welfare social worker, and colleagues. And the striking thing in the first part of the paper was the methods, whatever, that they reviewed 17 children who had died in the child welfare system with fetal alcohol and FSD. So what I'm saying is that there's things starting to emerge now in child welfare system that we may have been able to dodge it for the last 50 years and not engage it, but these things are starting to emerge. And obviously, a child fatality in the system is it's serious for the child welfare system.
No, of course.
It's serious for the social worker that's attached to that child that has on a caseload. So, you know, that whole scenario is happening. But on the whole, society is a little bit blasé about fetal alcohol. And, you know, I kind of said there to you that 13.6 is the alcohol rate in pregnancy in the US, but that has actually gone up 2 percentage points. It was 11 point something. So alcohol in pregnancy is going up. The other statistic about that paper, and it's GOSDIN 2022, GOSDIN 2022 at CDC. The other interesting thing about that paper was that it was data from 2015 to 2017. So you can't even say, well, the pandemic maybe is causing more, because it was pre-pandemic. Interestingly, you know, there's a really good paper was in the Lancet in 2020 from Jonathan Shear in Scotland, and he warned of collateral damage on fetal alcohol from the pandemic. That was at the very start of the pandemic. He warned of collateral damage, and I think the problem again is that is a medical journal, the Lancet, and probably child welfare officials, corporate parents, never read it. And if they did read it, would they connect the fact that the collateral damage is going to be mainly on social work and child welfare in the post-pandemic kind of concepts? No. So what I'm saying is that there is a real issue here for social work and child welfare. There's a lack of education. There's a lack of policy. There's a lack of procedure. And these families, and you mentioned there that you engaged with an adoptive parent on the podcast. These families are out there kind of scraping at doors, trying to get help and get supports. And yes, we are there as a profession that we should be given those supports. But at the end of the day, if we're not given the fundamentals ourselves, how can we do that support? And I think I know from my work in Europe, I did a lot of work with foster parents and with adoptive parents. One of the reasons that drove me into the PhD was a lot of them were angry with social work because they perceived social work not to have any empathy with them, not to have any understanding of what their dilemmas and their challenges were. And, you know, I'm constantly with caregivers, I'm constantly kind of saying to them, please understand that your social work is not given the training, you know, try and work with them. Anyway, that was me on a little bit of and you're very quiet
No,
there. So
well,
maybe you've got some questions in there.
I do have questions, but you said so much that I want to break down. I know for me, like I mentioned offline, I've been in the field 20 years. I started in child welfare. In my 3 years and change, I was in child welfare. I never heard about fetal alcohol syndrome. I know we focused on people, babies being born, positive talks to cocaine and other drugs, but in terms of alcohol, and I know the U.S. like if you buy any sort of alcohol, there's a Surgeon General label on it that don't drink if you're pregnant and things of that nature. That's the most like you will find in terms of like drinking and during like pregnancy. Going to grad school, 3 years and change of grad school, then I hear anything about fetal alcohol syndrome. And one of my professors worked in a outpatient rehab facility. Had I wrote a chapter in my book. Had like my my ex-wife being in rehab. Like nobody in the rehab talked about what is fetal alcohol syndrome. They didn't hear anything about that. So like I've been in situations where, and you said there's 50 years of research just here in the U.S. and not one time in 20 years until like recently, and it had nothing to do with social work that I found out about it and just wanted to like highlight this, like, hey, like we need to have this type of conversations because like you said, you know a child may not have the physical features, but they have cognitive functioning issues. There's evidence that kids like purposely like lie, and is like lies to a point where lying against their own parents and just making up a story, and it's like, oh, not lying, like, any kid will lie, but it's a certain type of lying and like
Yeah,
stealing and all this stuff that will cause a family to have a child welfare case, or at least be investigated for it. So there's all
yeah,
these like underlying symptoms that are not being being talked about. And
yeah,
yeah, nobody really in social work going, not too many people anyway are going to read a medical journal unless it's related to like a journal of social work, something with
yeah,
a title of social work, not something medical, unless like the doctor or some professor talks about it and brings it
yeah.
to attention. So
And
it's the lack of definitely education in undergraduate social work school, in graduate school, is definitely, even like I had 200 Latinx and social work book party, had over like 200 people. My majority, like 95% of social workers, and I want not one person mentioned fetal alcohol syndrome unless somebody was reading my chapter in the book. So
yeah,
it is not talked about at all, and
yeah.
especially with child welfare.
And I think that's, what I'm saying, that's the problem. But I think, unfortunately, what I'll say to you is that we do have, and we have got, I mean, you've got, say, Elizabeth Pomeroy down in Dallas, Texas. She's a social work prof down there. I remember reading Elizabeth's work about social work and what social work need to be doing and what social work should be doing. So you've got this pockets of where social work have been. I mentioned there Dorothy Bardry, again, another social worker in Canada that is championed a bit for social work. But I think throughout the world, there are social workers Here in the US, you've got Dan Dubosky. He's a master social work, I think, again, over on the Washington side. Dan does a lot on the mental health side of fetal alcohol. And he's written a lot and published a lot over the years around FSD. I think the problem is that they can get published, but they're not connecting somehow. And at the same time, a lot of the material that gets published does not necessarily give kind of any practical tools that people can maybe go and work with.
Right.
And I think that is kind of one of the difficulties, because certainly we can be awash with the awareness education of what is fetal alcohol, what is FSD, blah, 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 which is great. Okay, we're aware, but okay, what do we do now? How do we do it? When do we do it? All those are things, because you mentioned there a little bit of the neurobehavioral presentation. And the difficulty again for child welfare is that every child will present uniquely different because of the level of exposure, the timing of exposure, etc., that they've experienced. So every neurobehavioral presentation is going to have a different need. And again, it makes it difficult for the social worker, because if the social worker learns one specific approach to dealing with a child with FSD, it may not work for the next one. It may not work for the third one, etc. So that is part of the difficulty. The second part of the difficulty is that because child welfare and social work is fairly asleep on this one, these children tend to get diagnosed with many different diagnostics. So they have explosive defiant disorder, I think, is one of them, EBD, explosive defiant, I can't remember, explosive behavior disorder.
Right.
Yeah, that was it, explosive behavior disorder. That's kind of a new one that's come out in the last couple of years. You've got OCD, you've got ADHD,
right, ADHD,
you've got
right.
all of these. They all can look like FASD. And I think this is the problem that that child welfare has. Child welfare absorbs a high number of children with neurodisabilities, not just fetal alcohol, but there's a number of other neurodisabilities. In that little book I talked about that I did prior to the PhD, there is a breakdown of it in the book. I mentioned Williams syndrome, I mentioned Noonan syndrome, all these different syndromes that can look like fetal alcohol. And I think, you know, this is one of the problems that we have in the discourse at the moment, is that there's a danger of going from A to Z on fetal alcohol.
Right.
Yeah, because the neurobehavioral presentation can look like so many other neurobehavioral presentations.
Right, absolutely.
So how can we and how should we intervene in those cases? And how can we say, oh, well, I think that child's got fetal alcohol, et cetera, because they are behaving. Because again, I'm going back to saying the 15% with the facial feature, they are not a problem. They can be identified quite easily, and you have a diagnostic procedure. You need 3 facial features, you need blah, blah, blah. It's clear you can diagnose them. These other 85%, I'm saying, can look like so much further. And I think this is one of the problems for child welfare, is because the neurobehavioral looks like others, that they don't know how to separate it. Secondly, there is a kind of an overemphasis on the diagnosing of fetal alcohol. And so every second day now, there's a publication and it says early intervention diagnostics. I just explained to you, there's a real problem with the 85% of diagnostics.
Right.
And the 15%, that's not a problem. But papers will keep coming out saying early intervention diagnostic, early intervention diagnostic. There is no clinical diagnostic procedure that clearly captures this, because it is a fine wiring in the brain that has been disrupted because of alcohol as a teratogen travel to the fetus brain. So it is just disrupted. It has burned off, if you like, some of these neurons, and it prevented the synapses connection. Because again, if you ever look at a kind of a modern image of the brain, I mean, the old days, there were a hard skull concept.
Right.
But now you look at these images of the brain on the internet, and they're fine wiring, very, very fine wiring. Alcohol as a teratogen is very destructive to that fine wiring. And so I'm saying that on this neurobehavioral presentation, it's extremely difficult to diagnose it. And I think, you know, it's constantly been written about by certain researchers are saying there's no gold standard. There's no kind of, you know, this is coming out, but it's not been talked about. It's not been acknowledged, right, because it's a very dominant discourse that is talking about diagnosing. And so, again, I'm saying a little bit of cancel culture, that we cancel out the good science. And we keep this kind of narrative going in society. Very interesting then, I think I mentioned to you when we talked that Larry Bird and Slavona Pavlova. Slavona Pavlova is the social work faculty in Toronto. Larry Bird is here in the US. They have both been around.
Larry Bird, not the basketball player, correct?
No, no, he's not, you know. But they have both been around in the field of fetal alcohol now for the last 20 years. They have significant body of publications. They brought out a paper in 2019, and they kind of acknowledged that we have a problem. And they kind of said, like, because Pavlova has done a World Health Global Prevalence Rate, blah, blah, blah. But in this paper, that wasn't this paper, they assessed that we have about 11 million people in the world have some level of fetal alcohol harm, and we cannot, impossible, to diagnose them all. And in the paper, they clearly say that the children in the child welfare system, that they just need some modifications to adapt for them so that they can navigate the structure of life. And I feel like I was at the end of my PhD writing up, but I'd already got to that point of thinking, we can't diagnose. So I was delighted to see this paper, and kind of it kind of confirmed for me, because I had read a very sad coroner's report from a child that's named HLS, was the term used for the child, but he was a young man in Australia that was diagnosed very, very young, I think at 3 years of age. He lived with his grandma. Grandma cared for him until he was about 9, and she couldn't then cope. And he came into the child welfare system in Australia, and he basically, the neurobehavioral thing got worse and worse, and he broke down placements. He got into petty crime. He was glue sniffing. He was doing all this. So at the age of 15, the behavioral management technique was to ship him out to the most remote foster parent they could find in Australia, in the outback, because they thought if he's out there, he can't get in trouble. I think the first night he was there, he ran away and he fell into a pond, and he was killed by an alligator.
Oh, wow.
There is a significant, Linton is the coroner, there's a significant report documenting that child and the child welfare system's response to that child. But again, I'd read that, and I'd read that a guy called Dr. James Fitzpatrick, he had recommended that child welfare system should be doing just these functional assessments, yeah? Because the two most written about, the two most acknowledged deficits of an individual with fetal alcohol exposure are executive functioning and adaptive functioning. Now, there's other pieces, the sensory, but those are the two primary ones. Baz, we have truckloads of tools that can measure executive functioning. We have truckloads of tools that can measure adaptive functioning. Those assessments done correctly can actually show you where the child is weak, what the child is struggling with. Yeah. And adaptive functioning, you could do a Vineland, which I know that clinical social workers here in the US can do. They can do a Vineland. A Vineland, you might have a 14-year-old that is coming in at 8, 9-year-old because they're dismaturity, because they're not, capable. I'm saying to you, if you had that report and you're the caregiver, you're going to alter your care because now they're not 14 anymore, they're 9.
Right.
And again, it's about seeing a disability. It's about trying to visualize this disability. So the way that we can visualize this unseen disability is to do functional assessments. Again, with the executive functioning, we have bucket loads of tools out there that can measure executive functioning. And
So
again,
why?
this is what we should be doing with this cohort of children in our system. Again, I say, if you administer a Vineland or a executive functioning, you're not diagnosing a child. You're looking at the child's needs. You're looking at the functional piece of the child, and you're trying to measure that. So you're piecing together a potential pathway to maybe a diagnosis. James Fitzpatrick in the HLS report, he talks about child welfare system delivering these, blah, blah, blah. And if a diagnosis is warranted at the end of it. But I think he's hinting at the fact, sometimes when these functional assessments are done, the caregivers are actually feeling relieved because now they understand the child. Now they can adapt their behavior. I kind of say that, but I'm saying to you, because there's a kind of an incessant diagnose, which I think, unfortunately, it's a symptom of our world today, is that, every problem has to be a diagnosis,
Right.
And so we're diagnosing these kids, but in Canada, the last I saw, I think the diagnostic cost was between $4,500 to $5,000. I know in the UK it's around £3,000 sterling. So these are not cheap diagnoses. And what is the diagnosis? Well, it's a confirmation and it's a piece of paper, but quite often the caregivers are then coming back to get these functional assessments from the diagnosis. And I think we've got it all wrong. We're kind of doing it,
Right.
we should be doing this work. And this is where I suppose my narrative is around with social work and child welfare, is that we have to pull back into a social model of disability and pull back to seeing the child and seeing their need, rather than just looking for this quick label, or rather for looking for the label.
Right. Let me stop it right there real quick, because and what you're saying is fascinating and is a lot of education, and I hope people who are listening really pay attention to this, because really saying a lot of fascinating, great stuff. I wanted to ask, the last year and a half, I worked in the school system, and I know they do occasional functional assessments in terms of doing IEPs and things like that, and you bring up, we so focus on the diagnosis, and okay, the person comes in with a diagnosis, or a child welfare worker does the referrals for mental health treatment for a child. You already come in, okay, you're traumatized because you're in the system, let me refer you for the counseling. And you go see a counselor, and then you figure out, you start learning the families, and learning whether the parent is engaged in trying to get the child back and get him out of foster care. And I know for myself, I in child welfare, the foster parents wouldn't have this type of information unless the kid has been in the system for a while and the parents are not, involved to a point where we have to plan for a pre-adoption and for adoption. So that when the kid first come in the care, I know back then, I don't know how it is now, not much from talking to other social workers in child welfare, not much has really changed since I first started. Like I know for myself, I get a kid, coming in, brand new. I'm doing an assessment. The assessments that I'm giving is not going to be anything related to functional assessments. I'm more focused. Okay, the kid is in care. Let me refer automatically for some counseling. Is the kid in school? Does the kid need clothes? Does the kid has food and all this other stuff? Or we're going to do child welfare, Medicaid, or they have insurance. They focus on these other things that we're not going to focus on, like functional assessments. Or okay, we're gonna might find out afterwards. And even like working in a school setting, being involved in IEP meetings. Like I purposely, because of these last few years, at least knowing a little bit about FASD, like I brought it up. Like if a kid's struggling, on the functional level, I will ask questions. You think maybe the child might have some symptoms of fetal alcohol syndrome, and everybody's gonna be like, I don't know, that could be a possibility. Like they don't, that's not even a thought in their heads. Are we talking about, clinical school psychologists and things like that? They're not even thinking about that. So, and they're the ones doing the assessments.
Yeah, but I think ultimately, and that's where the gap is,
right?
Because these children are coming in. There is potential triggers in obviously what brought them into the care system. Have they come from an environment of drug and alcohol? Was there alcohol involved, etc.? You can have potential triggers of them of why they're coming in. But at the end of the day, you said there, like you might mention, this kind of fetal alcohol. I'm saying that we shouldn't necessarily go there. We shouldn't mention FSD. What we should be looking at is trying to piece together what is this child's needs. Now, before I talked about executive function and adaptive function, before the very first thing that I say that we should be doing, and this is where it sends panic in the system, I say we should be doing a genetic screen. Yeah. Because of the fact that the neurodisabilities, there's about 51 of them now out there in the system, that we are just trying to pick up. Could this child be a Williams syndrome, a Debut syndrome, a fetal alcohol syndrome, all of these other things? Now, again, ADHD and autism are not on a genetic profile, but there's a lot that is. Right. And so I think, again, a genetic screen here in the US is around $199. And it could be extremely valuable to actually putting this child down the right service track. Again, on a genetic screen, the only thing that you would look for is the panel of intellectual disabilities. It's a single panel. Because again, some families will get a little panicky about genetics. Oh my God, are you doing the parentage? Are you doing the kind of, is he the father? If all this sort of thing will start. Right. I'm saying, no, you're purely doing one thing, the panel of intellectual disabilities.
What is that?
Because in the genetic screening pieces, they call it panel. They call it panels. Okay. So normally if you go in with 3 or 4 panels, but you're only going in for one panel. And that panel is the panel of intellectual disabilities. So you're trying to pick up this hidden neurodisability. Now, with the fetal alcohol child, it should come back negative, because genetic fetal alcohol is not a kind of organic disability. It's one that's been caused. So it should come back. But if it doesn't come back negative, if it comes back with one of these other neurodevelopment disabilities, then you're very quickly as a social worker going to know, oh, there's services for that. There's services for this, or that child can go to that service, or we have those specialist carers that look after those children. We can go there, blah, blah. You're starting to see a pathway of where the child will go. So, that I personally believe that no child should be diagnosed with fetal alcohol unless they've done a genetic screen. Because there's lots of research that children are being misdiagnosed. and they're being kind of, yeah, that's out there. So a genetic screen is starting to weed out, and it's starting to kind of, is to kind of program in and to program out. So you kind of program in the fact that it could be a neurodisability that you're not aware of, because the profile is very similar, or it's not, and therefore you're moving on in the system. The second thing on my model is kind of talking about child behavior checklist. They're about $2 to do a child behavior checklist. A social worker and a foster carer could sit down and do a child behavior checklist very, very quickly with a child that has a neurodisability. And again, you're starting to see in a checklist, you're starting to kind of maybe measure, is this executive functioning problems that the child has, or is this adaptive functioning that the child has, or is it both? But then you're moving on to, I'm saying, these functional assessments. Then you're moving on to multidisciplinary meeting to discuss that. Then you're moving on to diagnostics. But I'm saying all of this process is not labeling the child.
Right.
And it's not putting a costly diagnostics on the process. Because I'm saying that the diagnostics is costly. And I'm saying that normally what I've seen happening is the diagnosis happens, and then the parents come back and they get exactly what I've described. But I'm saying that a lot of those, and it's like James Fitzpatrick said in the coroner's report in Australia, that we could be doing these things in child welfare system. We could be doing those sort of assessments. And if we're not doing them, we are
just social work in general.
Manager. Huh?
Just social work in general should be doing these assessments. If you work with a child.
Yeah. But I'm saying, like, you know, if you're not trained, I know that there's some social workers, clinical social workers that do violence. I'm sure they do executive functioning. They probably do DREFs as well. So that's great. In Europe, social workers are not trained in those assessments. And so it would be an upskill, an uptraining thing. But again, like, you know, that Pearson US, Pearson Canada, Pearson UK, they're the kind of general ones that have these tools. And they'll often come into a service and do some training on on their application. So, you know, it can be an easy thing for child welfare system to buy into. But I think in the whole thing, what I'm saying to you is that really child welfare corporately, firstly, has to waken up to the fact that this is a real issue. There's no room under the carpet to keep pushing it under the carpet. Yeah, we've got to start dealing with it, because there's more and more public failings starting to emerge, you know, of coroner reports, of child deaths. Last week we saw Nicholas Cruz in Florida not being given a death penalty, but given a life sentence. But the whole FASD was on the CNN news. It was on NBC, blah, blah, blah. Has he got fetal alcohol? Has he not got fetal alcohol? Was his mental health and his impulsivity linked to fetal alcohol? All of this was going on.
Oh, I didn't hear about that.
Nobody stopped to ask, why did we miss it? Why did we miss Nicholas in his development? Because now they're saying, yes, his mother was a significant alcoholic, that he struggled all the way through his childhood, but we missed it. But nobody wants to talk about that. You know, but I get a little bit peeved when I see main channel news talking FSD like this, yeah? Because I'm thinking, wait a minute, 50 years of research, we shouldn't be here. We shouldn't be here.
Right.
And unfortunately we are, and these things keep happening. And I'm saying that society has to waken up and start acknowledging. Now, I started out by saying the US is in a good place in terms of alcohol rates in pregnancy. You have them down. Canada is 10.4 as a national figure. Now, I think that moves from, I think, 5.4 in Prince Edward Island to, I think, like 27% in Quebec. So there's a variation on that. There's a variation in the US, and we talked about that as well. Europe, crazy, crazy high levels. And I know that my research is Irish, and I know my doctoral study has gone back to the child welfare system in Ireland. I can only pray that they will try and implement But equally, I try and give direction in terms of what this, the prevention messages. I would love to see prevention of fetal alcohol going into second level education, because I think adolescents are a lot better at taking stuff on board. And so even a half hour in second level education on alcohol and pregnancy would probably sink in a hell of a lot better than maybe a whole day's training when they're 25, 26,
No, absolutely. And it's funny you mentioned that, because even like, health class in high school or whatever, they just touch real brief on just alcohol and pregnancy, and it's like, and it's just like, think about here in the US. I mean, I don't know anything about Europe, but just like kind of relaxed attitude just to alcohol, and it's just, you know something simple. Oh, you want to drink? Like, it's just like it's like something simple as, you want to drink is like the same as like, hey, how are you? And it's like, it's kind of just relaxed. Like, people don't really pay no mind. People don't really ask questions like, why is the liquor store on the corner open at 9, 10 o'clock in the morning? Like, who who goes to the liquor store like 9, 10 o'clock in the morning? And it's like, and then pandemic hit, and it's like, no, liquor stores or essential businesses, and is like, which really like annoyed me that it was. And just people just have just this relaxed attitude, that people look at you if you go out somewhere to a bar and like you don't have a drink, you just have like water or seltzer water, like, or things like that, and it's like people look at you like, what's wrong with you? And even like, you think that 13% pregnancy could be higher if there wasn't a stigma of like parents or admitting that they're drinking alcohol while being pregnant?
I don't know. I mean, obviously, that I'm saying all studies are open to that kind of concept, that people may not tell the full truth. I think that consistently in the US, the figures have been hovering around 11, 12%. So they're slightly up. I would think it's a fairly good figure, and I think it's a fairly standard figure. I think one of the difficulties of the whole issue is that, certainly that pandemic, I think a lot of the off license went to online shopping and blah, blah, blah. Mm-hmm. And I think we have to, I would encourage child welfare to read Jonathan Shear's paper of 2020 that was in the Lancet Journal, that is warning us of this kind of collateral damage that is coming down the line, because I think child welfare is going to see an increased level of fetal alcohol coming in. And I think that the problem is, like, that we have to kind of join the dots in the process. So I'm saying to you, the US is in a good position. Mm-hmm. I mean, as you say, the Surgeon General in 1986, that alcohol warrants you. Go into a pub, you can see the thing on the wall. It's right. It's on the bottles. It's whatever. So you have made massive progress. When I say to you that Europe is 82%, 71%, blah, you have a lot to be proud of in the sense of the public health approach, right, and what has been achieved. Now, it still doesn't mean that there isn't cases presenting in the child welfare system, because unfortunately the child welfare system globally is picking up this, because it's a neurobehavioral, neurocognitive profile. I think the problem, and we didn't talk about, it was written into your child protection legislation in 2010 with the Reauthorization Act of 2010, made FASD a mandated duty of social work. And I don't think many social workers are aware that even that happened. No, and my little concern there is that, again, is that social work is vulnerable, because that's in the capital legislation now, that the social worker has to plan safe care for the child with fetal alcohol. I talk to social workers and they look at me blankly and they say, well, I don't know. But
I
if
just
it's
looked
in
at you blankly.
legislation, if it's in statutory obligation, then that kind of leaves you a little bit exposed, no?
Mm-hmm.
And this is where I say to social work, I again have talked to social workers throughout Europe. I talked to social workers in Canada. I've talked to a couple here. They're all looking at me blankly. I'm saying social work has to voice up on this because social work is vulnerable. These kids are on your caseload. These kids are coming in. You're not being given. And I kind of come back and say, we have the tools from that 50 years of research. We know what will work and what won't work. We know what can help create a pathway for social work to deal with these cases. It's all in the research, but it's been cancelled out by a kind of a social media narrative on fetal alcohol that confuses and blinds people. But I'm coming back and saying, statutory obligation. The World Health is jumping up and down about fetal alcohol. It keeps kind of, public health, chief medical officers, they're all saying it. It's now, according to Canada, 2019, Johnson in Canada brought our cost burden and put it at 10 billion a year. So again, you know that our health system cannot sustain those sort of costs rising.
Right.
Given that it's a cost that can be prevented, I'm the first to acknowledge we'll never get to a utopia. We'll never find that we'll eradicate fetal alcohol.
Right,
but I think we have to keep at it and we have to be aggressive at it. But again, I'll say it's not about blaming women. Women need to be empowered. Women need to understand that alcohol as a teratogen poses the risk. How we inform women, how we empower them to make their own decision around a safe pregnancy, that is the challenge of public health. And again, I kind of come back and say, if we brought it into second level education, if we kind of, because when a woman walks in and sees that thing in the pub, okay, it's telling her that, but it's not really telling her why, or it's not really telling her what the biology of risk is when she sees it.
Right.
I'm saying there's really good public health information. It should be in our doctor's surgery. It should be in our health centers. It should be in our social work offices. It should be whatever, so that we can push it out. Women can pick it up. They can read it. They can read it in their own time. Certainly, that's what I'm kind of recommending in my doctoral study for my own culture, is that we need to empower women to understand that risk. Because I have trained, my last CPD day before the PhD was 26 social workers from child welfare. 24 were female, 2 were men. Mm-hmm. But you probably agree that that's kind of usually the statistic.
Yeah.
Yeah. Not one of those women had any offense to the education. And in fact, they rated and the evaluations were extremely high. Things like, I'm going to go back and tell my colleagues, I'm going to go back and share this with my colleagues, et cetera, et cetera. So again, I come back that there is a training framework for training social work. It was the one that I did in 2011. It's the one I did in Europe. There is a training framework there. But again, social work needs to voice up and ask for that training and ask for some procedures because they are vulnerable. That's my rant. Social Work Rants podcast. Yeah.
No, I love it, and it is so true. I mean, we always guard against to make sure we protect ourselves, with our license and we have like insurance and stuff. But you're right. Like if a kid experience having just want to lie and or steal or do these things and is based on symptoms related to fetal alcohol syndrome, and you're thinking they're just being a pain in the ass and and it actually has like symptoms of fetal alcohol syndrome, you're not going to know that unless you like your actual trainer and try to rule that out.
Yeah. And I'm saying, yes, these children are often seen as difficult kids, as problem kids, as there's nothing can be done for them, blah, blah, blah. They are the child that tends to break down foster placements. They can have 6, 7, 10 foster placements. They can go through all of that. But I mean, if you're a social worker and your kid is in the 5th placement, it's kind of telling you something. There's a sign there that there's something going on. Again, I'm saying we shouldn't jump to fetal alcohol. We should think about neurodisability, that there's a neurodisability potentially in this child, and that we need to start working that out. Which one is it? Which neurodisability is it? What could it be? Blah, blah, blah. But we need to do a checks and balances in the process. Rather than saying, oh, it's fetal alcohol, let's go and get a $3,000 diagnosis, which might be wrong. Yeah. So
Yes.
this is where we have to come back at it. But I do say there's a thing called FASD informed, and social work and child welfare social work need to be FASD informed, because they are encountering these kids at probably a higher rate than they're aware of. Yeah. I often think that a quarter of a social worker's case file could be impacted by fetal alcohol based on the statistics that are there in terms of prevalence rates. So many social workers are not seeing it. They're seeing the problem child, they're seeing the difficult child, they're seeing it's tagged as ACEs, it's tagged as trauma, it's tagged as ADHD. You know, we have all these nice labels that we can chuck out and give a, you know, that's it. The problem with labels, and we chuck them out and we give them to children, but we often then follow them up with medications. And you have children taking these heavy medications. Again, fetal alcohol doesn't have a medication base to change it. There's medications that can help with the neurobehavioral piece, but that's a very technical piece that has to be done in pharmacology. But I'm saying that, yeah, we are misdiagnosing, we are mismanaging, we're mismedicating, we're sending them down the wrong service stream. I worked in secure accommodation in the UK. I can remember clearly, before ever I came to fetal alcohol, I can remember clearly that secure accommodation, adolescents, blah, 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 serious crimes. I can remember these kids that were popping Ritalin at the time. Ritalin was the smartie of the time. And Ritalin was supposedly for the ADHD and for the behavior.
Right.
I can remember having countless conversations with my colleagues saying, it's not making a bit of difference. There's nothing. You know, this kid is popping Ritalin, but nothing is happening.
Right.
And I think quite often what happens with social work and indeed with carers is they see this as well. They see that the child is diagnosed, the child is taking medication, but nothing is happening. Clear sign that you've got a wrong diagnosis. Clear sign that, you know, you need to come back to the drawing board. And again, I'm saying, rather than going through this kind of diagnose this, medicate that, diagnose this, medicate that, let's go back to this functional assessment piece, this genetic screening, this child behavior checklist. Let's do checks and balances before we ever go near diagnoses, so that we know that we're taking the child in the right path. That's kind of the core of what I'm saying that we need to be looking at in child welfare. And I think we need to be kind of buying into this whole social model of disability. Mike Oliver was the kind of creator of the social model back in can't remember when he was now, but Mike Oliver has done a lot of work in how we society and how disability is viewed in society. But the social model of disability, again, I'll say to you, you know that a diagnosis is a day or two in a clinician's suite. Please remember, for the child with an FSD, they have a life to live. They're in the school system. They're in their carer system. They're and they still have their neurobehavioral problem.
Right.
So if we're not seeing that social piece of their need, or we're only hanging it on a diagnostics or hanging it on medication, we failed, and we fail in these kids. And
Right,
unfortunately,
absolutely.
what I kind of opened up at the beginning saying, we're starting to see this emerge now in child welfare, because I say, once one public health coroner starts writing about it, you can guarantee that other public health coroners are going to start writing about it.
Right.
And
Wh-
it's going to become more. And I guess me talking on this podcast will probably trigger a few people off on that as well. But it's there. I mean, I'm not talking anything that isn't there out there in the system that people can go and read. And in my thesis, I recommend to the child welfare system that it would be better if they read the coroner reports listed in the back in the bibliography, because the coroner reports often give good direction to where the child welfare system is failing on these kids and what needs to happen.
No, why I asked like the questions, at least from my experience doing IEPs or being part of IEP meetings, because the child is gonna have this diagnosis, the rest of his life, just like you want to throw any label diagnosis on anybody, but it's affecting functioning, executive functioning, and it's stuff you don't see to a naked eye. And like you're gonna have adults with issues with executive functioning, cognitive functioning, and it's like they got to learn how to deal with money and deal with people, and they get taken advantage of easily. And you look at them, and you, unless they have the certain features, you can't tell that they have a, a, a disability. So
And
it's
it's difficult.
yeah.
And you talk there, like, the dismaturity piece in these individuals as children, as youth, but yes, they grow into adults. I think the problem is that, there's an unspoken narrative out there that they grow out of it. And people will say, oh God, no, they don't grow out of it. No, FSD is a lifelong disability. I think what happens is that the dismaturity, because if I'm 16, but I'm operating at a 12, and that's seen, but when I'm 22, I'm operating at 16. But when I'm 28, I'm operating at 22. Yeah. When I get to 22, society is not interested in me. Once I've left the child, the 0 to 18 piece,
Right.
nobody's going to measure me. Nobody's going to say, well, you're a bit slow, or you're not managing your money, or whatever. And so there's an element of the fact that some kids they can manage in society once they get into that adult piece, because they're not under this assessment piece or this people telling them they should be doing this or they should be doing that. So they can manage. I know that a lot in the FSD world will be angry that I say that, but I do say it in the sense that, I can come back to one thing I haven't said in the whole thing. FASD, it's mild to severe. Yeah, you get a whole spectrum of children within that. Now, what Bird and Pavova said is, I think a lot of the mild and moderate, they just need accommodations of their disability in order for them to function and function well. There's a percentage that may need a full diagnosis. But I'm kind of saying that, that we have a real problem that there's no clinical guidelines for that 85%. And we're chasing the holy grail of diagnosis when it's not there. I mean, and again, I'm saying I'm 10 years in this education process. So I'm saying yes, maybe in some of my earlier publications, I would have talked about FSD and diagnosis. My doctoral study has changed me. And I've kind of now come around to the fact that we have to be very, very careful with the whole diagnosis thing. Certainly that children that are not stable should never go near a diagnosis. If it's an adoptive parent and the child is stable, secure, has a loving family, free from violence, a diagnostics may be appropriate. But in the foster care system, where there's the instability, then a diagnosis is not relevant. And I think what we come back to is this functional assessment piece should be what we're looking at,
Right.
and should be how we go, which is coming back to what Bird and Pub always said we should be doing. And it's coming back to a social model of disability. And it's kind of getting us getting our head out of medical model, getting us back into something more pragmatic, something that we can actually do.
My last question is where us in the social work field, where could we get our hands on these type of functional assessments, and how can we go about talking to our agencies that, like, hey, we need these functional assessments to try to help us learn our clients better, learn these kids better, and so we can help the parents and foster parents who are dealing or with these kids 24/7.
Yeah. Well, I kind of said to you there in the time, I said that Pearson is that educational company. They're all over the world. So they're Pearson US, Pearson Canada, Pearson UK. They will often, they have these tools. So I talk about in my doctoral study, I talk about executive function. I talk about the DREF, the Dilius rating of executive functioning. And I talk about Vineland 3 for adaptive functioning. Those are the two that I talk about in the thesis. I think I clearly say in the thesis that you don't have to use those tools, but you must use executive and adaptive functioning. And what I'm saying is that each culture may have slightly different tools that does the same thing. Yeah. So that's the primary place that you would access. I've said, and I kind of say here publicly, that for child welfare systems, I know that Pearson will come out and do a presentation of their tools to, say, child welfare policy officers, etc., that show them how these tools work.
Right.
So it's not brain science in a sense. It's pretty straightforward that we can do this. And these tools are less than $10 each as an individual tool. Now, where they go into assessments of independent practice, etc., they get more expensive because of the independent practitioner obviously charges much higher because of their time, etc.
Right.
Going back to what Dr. James Fitzpatrick said in the HLS report, these can be trained in-house. These can be delivered in-house. And they should become regular tools in the social worker's toolbox. Yeah. The child behavior checklist is $2 a penny. It was developed by a guy in California, Ansbacher. I can never pronounce his name, so I'm going to say a guy in California. The only criteria for administering the child behavior checklist is that you have 4 years qualification. So a lot of masters, social workers, etc., and whatever will have got that 4-year piece with their bits. So they're well able to administer and score a child behavior checklist. Again, I'm saying to you, Baz, it's about $2. Yeah, it's very, very cheap, but it actually is extremely valuable to start to break down, because quite often the social worker, the caregiver, will be given all this anecdotal evidence of the child's behavior.
Right.
But you sit down and do a child behavior checklist, you're creating an evidence-based practice piece. You're creating the evidence to actually see where we're going with this child, rather than dealing with the anecdotal evidence of what the caregiver is saying or whatever. Again, I recommend the social worker and foster care sit down together, do the child behavior checklist. It's about $2.
Awesome.
Again, I'm coming back to a genetic screen. If you're thinking there's a neurobehavioral piece going on here, there's something not that, it's $199. But your child welfare system will need to develop a protocol and an ethics form for doing that. Now, if you're going to a private provider to do a screen for the genetic panel of intellectual disabilities, again, I'm saying it's about $199. You will need to have a protocol in place between the child welfare system and that private provider. You'll need to have an ethics form that the parent or carer can sign. Again, I'm saying the parent and carer shouldn't be upset about this, because you're not going to delve into their personal history, with the genetic screen. You're purely looking for this one thing. And it's vitally important that that's all it's about. But again, I'm coming back. So what I'll say, Baz, is that if any policy officers are listening to this podcast, I would love to talk to them. I would love to kind of tell, to talk this out in a more pragmatic way about how they could support their social workers in doing these type of assessments, doing these sort of interventions. So I'm throwing out an open invitation to policy officers to get in touch via you.
No, absolutely. Where can people find you?
Well, obviously you found me on Twitter. So I'm Dr. Liam Kern on Twitter. It's William, I can't remember, it's all those figures. But
there's numbers after
Google
William.
You'll Google me, you'll find my publications, you'll find my history. I give a caveat saying that all my publications, including my doctoral study, I'm a qualitative researcher. I collected data from frontline professionals, and all of those frontline professionals are Ireland and what I collected. The doctoral study was 11 child welfare social workers. It was a psychologist. It was a midwife. It was a staff development officer. It was 3 foster carers. And I've forgotten someone. I'll be in trouble. There was 18 of them in it, but they were primarily social work, and it was a social work-led study. And really this kind of concept of this neurobehavioral screening tool that I keep talking about, that's what came out of that data, and that's what came out of that analysis. And I very much see it as a pathway for social work, because the thing that I've heard most in 10 years of this work is social workers telling me they have nowhere to go with this. Right. They don't know what to do with it. Quite often they know they're dealing with it, they can see it, but they have no idea what to do with it. So I'm trying to advocate that there is a pathway, but I could go out tomorrow and train 24 social workers without their policy team acknowledging the procedural pieces of them putting that education into practice. It's pointless doing that training. Right. So it has to be hand in hand. I often think, because I did CPD in Europe, I do often think I feel sorry for those social workers now, because I gave them the knowledge, but how can they put it into practice? Right. That worries me about FSD education. If it's not backed up, if it's not hand in glove with a policy procedure piece, then it's likely to fail. And I'm saying the child welfare system has got away with this for 55 years. It's going to have to wake up, because with children fatalities in the system, the child welfare system is going to have to do big settlements to these families. Because if we take these children into the care system and we say we're going to care for them and they end up in a fatality, you're going to have to compensate those families. Right. So fetal alcohol is getting more and more and more costly.
No, absolutely.
And yet the training and the policy procedure is miniature in comparison to what those costs would be.
No, I agree. I'm going to put your Twitter handle in the show notes. We could talk all night about this, because this is fascinating. No, it was a pleasure meeting you. Thank you so much for coming on, Dr. Curran, and we'll keep chatting on Twitter.
Send me a DM if you want to chat again or whatever. And,
yes, absolutely.
If you get any feedback that's good, bad, or indifferent, let me know. I mean, I don't know if you noticed on my Twitter, I tweeted something about the difficulties social workers have in time and case management and blah, blah, blah. Somebody came in on me and said, FSD is medical. It's nothing got to do with social work. Social work shouldn't be doing anything with FSD. And I was like, okay. So, and those are the problems in society, that society has this kind of, they're confused. There's a lot of confusion and contradiction, No, absolutely. I will stop.
Thank you again so much. We'll talk soon.
Yeah, listen, welcome, and thank you so much for having me. And I hope maybe that it can connect with people and that they
I hope so too.
Like what they hear. I am advocating for social work. I do say that social work is vulnerable here and we need to step up.
Absolutely.
Okay.
Thank you. Take care.
Thanks a million. Take care. Bye-bye.